Hello everyone, and welcome to this initial audio podcast. This initial audio podcast is part of the this audio podcast series is part of the syndicate. This audio podcast is part of the Bostic syndicate. This audio podcast is part of a as part of a Storm and Saga analysis, and this audio podcast as part of a Storm Robotics production. In this audio podcast, as part of the Bostic Syndicate and this and the Squallish, and then as part of the Squallish series or edition, initially looking at a snapshot in as part of looking at laboratory tests, biomarkers and investigations. So chronic kidney disease or CKD generally has five five aspects in regard to, in as part of that in as part of classification, and wherein each classification wherein each CKD classification has its own CKD severity. The severity is determined in as part of laboratory investigations, and wherein a particular biomarker is utilized to determine and to also identify renal function or renal insufficiency, and then referred to as estimated glomerular filtration rate, or EGFR, or glomerular filtration rate, GFR. And each classification is on the basis of CKD stage 1 through 5. There have been publications in regard in around particular workings in around CKD stage 3, since in literature retrospectively, CKD stage 3 has a basis where it is divided in CKD stage 3A and 3B, and on the basis of the estimated glomerular filtration rate between the two divisions, but at the same time, listeners and viewers, that the CKD stage 3 is a CKD stage 3. There have been publications to sort of offer the basis of omitting CKD stages 3A and 3B, and to have it replace it with CKD stage 6. CKD stage 6, for example, owing to the divisions on CKD stage 3A and 3B being where the EGFR, estimated glomerular filtration rate, is evident, is in amongst the literature, is sort of a narrow margin between CKD stages 3A and 3B. So now moving into looking at creatinine. So creatinine is one of the main biomarkers, and creatinine is a routine biomarker utilized or used to determine renal function or renal insufficiency, and it is a byproduct. It's a byproduct of muscle breakdown, and excreted through and by the functional components of the kidneys, being nephrons. being the nephrons. The normal range of creatinine is anything between 60 to 100 micromoles per liter. Although that being said, the um, the the um, the in around laboratory investigations, as part of laboratory investigations, the normal range or reference range for creatinine can also differ depending on where creatinine is being used is being used to determine renal insufficiency or renal function. Then additionally, when the kidneys sort of begin to fail, or where there is a sense of renal insufficiency, the creatinine goes up as the renal function or kidney function goes down. Creatinine levels may be either very high or very low in sort of early stage of a diagnosis. Uh, Now, as part of estimated glomerular filtration rate specifically, EGFR is a clinical standard to determine estimation of renal function. EGFR is utilized to for in around as a base of definition and staging of CKD or chronic kidney disease. EGFR sort of equations and calculations are utilized to determine renal function and renal filtration, and biomarkers are also biomarkers are sort of additional biomarkers in as part of laboratory practices are and have been used in conjunction. So, for example, serum creatinine, and or with cystatin C with other parameters. And now going into a look at sort of blood urea and nitrogen. So BUN, blood urea and nitrogen. Urea is a molecule excuse me, is a molecule produced from mainly from sort of where urea as sort of as part of a waste produce is excreted by the kidneys, and the level of urea in blood rises or increases in renal insufficiency. The amount of the amount of urea the amount of urea can also can affect sort of the laboratory analysis. The value can also rise, can also increase if where there is a sense of dehydration. The normal value, at least where in amongst the literature is or has in amongst the literature has been anything between 2.5 to 6.6 millimoles per liter, according to the general population. To the general population, and population in amongst the adult healthcare population, and in pediatrics and young people, the normal value in around urea is somewhat similar, but at the same time varies in pediatrics and young people. Urea is also accumulated in blood, accumulates in blood, as part of blood physiology, or blood in around hematology, and as part of CKD, and it is not an accurate investigation or a laboratory investigation for renal function alone, but it is useful when used with serum creatinine or creatinine investigations. Now looking in as part of potassium. So potassium comes from various nutrition, fruit, vegetables, and in around in around in around pe- in around yeah in around fruit vegetables, and potassium tends to rise in people can tend to rise in people with renal insufficiency, and the levels of potassium can also rise or can increase with some pharmacotherapeutics, and it can be sort of dangerous when the kidneys do not function adequately. High potassium levels can also be treated by giving sort of by giving or prescribing other sort of pharmacotherapeutics. And for the purpose of this audio podcast, those pharmacotherapeutics will not be mentioned. If the potassium level is high and kidney function is low, then a form of renal replacement therapy or a form of kidney replacement RRT or KRT, in the form of dialysis. Dialysis, for example, is important, is and becomes sort of important. The normal range in the normal range for potassium in amongst the population, the general population, is anything between 3.5 or 3.6 to 5.0 millimoles per liter. Again, the reference range of potassium varies depending on laboratory practices in amongst different sort of regions. And now a quick look at sodium. Sodium comes from salt. It increases when the kidneys do not function well. Increased sodium can cause anomalies in around ABP, arterial blood pressure, and where and in around OD, where one of the symptomologies can be edema or swelling, and fluid, and where fluid or edema is in on the is on the on where the edema affects the respiratory system, and in around sodium, diuretic pharmacotherapeutics also sort of can increase sodium within avoided urine. Most renal recipients tend to tend to be tend to be tend to be informed that to reduce, for example, salt intake or sodium intake sodium or also salt intake. And then the normal value in amongst the healthy population is anything between 135 to 145 millimoles per liter. Again, the reference range of sodium can vary depending on the where the laboratory investigation is, and it can vary depending on where the laboratory investigation is in amongst different regions, for example. And where there is renal insufficiency, the sodium rarely changes directly. So now looking at anemia. Anemia is increases progressively as EGFR declines to lower than 60 mL per liter per min per 1.73 meters squared. Anemia is associated with poor outcomes, including higher mortality in patients with ESKD or end-stage kidney disease, and in those with non-dialysis dependent CKD. The prevalence of anemia is generally high in patients with with non-dialysis CKD, and increases as CKD progresses being present in approximately in amongst literature has been evidenced as in around 42% of recipients with CKD stage 3, although literature has not informed has not informed in around where where there is a difference, a sort of difference between anemia parameters between CKD stage 3A and 3B, although in pediatrics and young population, where in around CKD, anemia may be anemia tends to be more tends to be and can be more sort of obvious, and then at the same time this increases or can increase to approximately from 42% to 76%, or around just under 80% in CKD stage 5. Non-dialysis CKD and recipients on KRT or RRT have additionally sort of where anemia is concerned can have disorders in around iron metabolism due to increases in increases in a particular biomarker being hepcidin, the sort of regulator of iron absorption and release from cells. And now I'll look at a quick look at different forms of RRT and KRT. So in around hemodialysis is a form of RRT or KRT whereby there is a process of removal of toxins and waste from blood. The treatment does not completely perform all function of renal anatomy or renal pathophysiology. Dialysis at the same time, or hemodialysis, is prompted when an individual reaches ESRD, end-stage renal disease, end-stage renal disease, and end-stage renal disease in literature is synonymous with terminology being end-stage kidney disease as well, ESKD, and where filtration rate falls below 15 ml per min per 1.73 meters squared. Now, in a publication, where, as per mentioned, there is some sort of debate, for example, that in around CKD stages that CKD stage CKD stage 6 is and should be implemented to replace or omit CKD stages 3A and 3B, and thus where CKD stage 6 would be concerned, then the EGFR or the GFR would be determined as less than 10 ml per min per 1.73 meters squared. And the procedure in around hemodialysis or as a form of RRT, the procedure is responsible for additionally for the development of oxidative stress. In around sort of the less invasive form of RRT or KRT, there is peritoneal dialysis. Peritoneal dialysis tends to involve using the peritoneal membrane as a filter inside the abdomen. A catheter is inserted into the peritoneal cavity, and it is recommended for younger patients or children and young people because of its flexibility. It can be performed at home. So it can be performed in recipient's residence at home, and the patient must be capable. A patient or recipient must be capable to perform the technique, or have a carer or parent or guardian. One of the sort of the challenges around PD or peritoneal dialysis is that peritonitis or inflammation of the peritoneum is one of the most common sort of infections and complications of PD treatments. And then finally, looking at specifically in around iron deficiency. So in as part of this audio podcast, there was a sort of an overview in regard to anemia and sort of low hemoglobin. But iron deficiency, iron again is sort of essential for many important biological and physiological and pathophysiological reactions, including oxygen transport, cellular respiration, and DNA synthesis. Systematic iron balance is maintained by regulating nutrition, iron absorption, and iron release from storage from physiological pathophysiological storage sites in addition primarily in amongst the liver. CKD patients or CKD recipients have can have symptomologies in increased iron losses and where estimated where in literature the iron loss is and can be estimated at 1 to 3 grams per year in RRT recipients due to chronic bleeding, or where bleeding occurs from uremia associated platelet dysfunction and frequent phlebotomy frequent phlebotomy and blood trapping in RRT or KRT apparatus. That draws this audio podcast to a close. There will be a sort of a list of citations or references in as part of this audio podcast on social media. This has been an audio podcast as part of the syndicate. An audio podcast as part of the Bostic Syndicate. This audio podcast is part of a Storm and Saga analysis. This audio podcast is part of the series The Squallish, and this audio podcast as part of a Storm Lobostics production.